There is a bottle in almost every medicine cabinet in America. It has been there for decades. You have reached for it after a long day, after yard work, after a sleepless night with a bad back or an aching knee. You have given it to family members. You have recommended it to friends. And you have done all of this because for most of your adult life, the message from every direction, television commercials, physicians, pharmacists, the label itself, was that this medication was safe, effective, and appropriate for everyday use. The medication is ibuprofen. You know it as Advil, sold by Haleon and available at every Walmart, CVS, Walgreens, Target, and grocery store in the country. You know it as Motrin IB, sold in the same locations. You know it as the generic ibuprofen 200 milligram tablets stacked in bulk bottles at Costco for under $10. And you have almost certainly taken it within the last 12 months without a second thought. Here is what the research now shows with consistent, reproducible clarity, and what almost nobody over 60 has been told directly. The biological changes that occur in your kidneys, your cardiovascular system, your gastrointestinal tract, and your brain between the ages of 40 and 70 fundamentally transform how ibuprofen behaves inside your body. A dose that was genuinely low risk at 45 is genuinely high risk at 67. Not slightly more risky, significantly more risky. Risky in ways that produce outcomes, kidney failure, heart attack, gastrointestinal hemorrhage, dangerous medication interactions that happen fast, that are often irreversible, and that kill people who had no idea that the pill they took for their knee pain was capable of doing what it did. I am not here to alarm you without cause. I am here to give you the precise biological explanation that your last 3 doctor's appointments probably did not include, so that you can make an informed decision about a medication that tens of millions of people over 60 are taking right now without that information. Stay with me through this, because the more clearly you understand what ibuprofen actually does inside an aging body, the more clearly you will understand why the alternatives I am going to give you at the end of this are not a compromise, they are an upgrade. And before we go any further, if you are over 60 and you take ibuprofen, drop a 1 in the comments right now. I want to see how many people this directly applies to, and if you are not subscribed, hit that button so you do not miss what is coming next. To understand what ibuprofen does to aging kidneys, you need to understand one fundamental fact about kidney function after 60 that most people have never been told. Your kidneys lose approximately 1% of their functional capacity every year after the age of 40. This is not a disease. This is normal physiological aging. By the time you are 65, you have already lost roughly 25% of the kidney function you had at 40. By 75, that number approaches 35%. And here is the critical point. This loss is largely invisible. Your blood work may look acceptable. Your creatinine levels may appear normal. You feel fine. You have no idea that the organ silently filtering your blood every minute of every day is already operating at reduced capacity because kidneys compensate remarkably well until they cannot. Ibuprofen belongs to a class of medications called NSAIDs, non-steroidal anti-inflammatory drugs, and NSAIDs work, in part, by blocking the production of prostaglandins. Prostaglandins are signaling molecules your body uses throughout your entire physiology, and one of their critical roles is maintaining the blood vessels that supply your kidneys. When prostaglandin production is blocked by ibuprofen, those renal blood vessels constrict. Blood flow to the kidneys drops. In a young adult with full kidney function, this temporary reduction in renal blood flow is manageable. The kidneys adapt, the medication clears, function rebounds. In an adult over 60 whose kidneys are already operating at 70 to 75% capacity, that same temporary constriction can cross a threshold where reduced blood flow becomes ischemic damage, where kidney cells that were already doing more work with fewer resources begin to die, where what started as a few ibuprofen tablets for lower back pain ends as a hospitalization for acute kidney injury. The American Journal of Medicine published data showing that NSAIDs, including ibuprofen, are responsible for approximately 10% of all acute kidney failure cases in adults over 65, not 10% of cases caused by medications. 10% of all acute kidney failure in that age group. This is one of the most preventable serious medical events in elderly adults, and it is almost entirely driven by over-the-counter ibuprofen use that nobody supervised. The risk compounds dramatically when you add dehydration, which older adults are chronically more susceptible to, because dehydration already stresses renal blood flow before the ibuprofen arrives to make it worse. It compounds again when you add other medications. ACE inhibitors like lisinopril, sold as Prinavil and Zestril, which are among the most commonly prescribed blood pressure medications in adults over 60. ARBs like losartan, sold as Cozar. Diuretics like furosemide, sold as Lasix. All three of these medication classes affect renal blood flow through their own mechanisms. Combined with ibuprofen, the triple interaction, called triple whammy nephrotoxicity in the clinical literature, is one of the most reliably dangerous drug combinations that primary care physicians see in elderly patients. It causes acute kidney injury at a rate several times higher than any of these medications individually. If you are taking any blood pressure medication, any water pill, or any heart medication, and you also reach for Advil or Motrin when you are in pain, you need to bring that combination specifically to your physician's attention at your next visit. In 2015, the United States Food and Drug Administration strengthened the warning label on all NSAIDs, including ibuprofen, to state that these medications increase the risk of heart attack and stroke, and that this risk can occur as early as the first week of use. Most people over 60 have never read that warning. Most people over 60 who have read it have interpreted it as the kind of legal boilerplate that appears on everything. It is not. Here is the biological mechanism. Ibuprofen blocks two enzymes, COX-1 and COX-2, both of which are involved in prostaglandin synthesis. COX-1 activity in platelets produces thromboxane, A2, which promotes blood clotting. COX-2 activity in blood vessel walls produces prostacyclin, which inhibits clotting and causes blood vessels to relax and dilate. When ibuprofen suppresses both enzymes simultaneously, it does so unevenly. COX-2 suppression reduces prostacyclin production in blood vessel walls more efficiently than it suppresses COX-1 in platelets. The net effect is a shift in the body's clotting balance, away from the natural anticoagulant signals that keep blood flowing freely through vessels, and toward a prothrombotic state in which clotting is more likely. In an adult over 60 with already stiffened arterial walls, reduced elasticity, accumulated atherosclerotic plaque, and a cardiovascular system that is operating closer to the margins of safe function, this shift in clotting balance is not trivial. It is the precise physiological environment in which heart attacks and ischemic strokes occur. A large European cohort study tracking over 8 million adults found that current use of ibuprofen was associated with a 31% increased risk of major adverse cardiac events, including heart attack, compared to no NSAID use. The risk was higher in adults over 65, higher in those with pre-existing cardiovascular conditions, and higher in those taking ibuprofen at doses of 1,200 milligrams per day or above which is 2 to 3 standard Advil tablets, a dose that millions of people take without considering it significant. There is also a blood pressure mechanism. Ibuprofen causes the kidneys to retain sodium and water, which increases blood volume, which directly elevates blood pressure. In clinical trials, regular ibuprofen use raises systolic blood pressure by an average of 3 to 5 millimeters of mercury. That number sounds small. Over months of daily or near-daily use, it is not small. Elevated systolic blood pressure is the single most modifiable risk factor for stroke, and medications designed to lower blood pressure, including beta blockers like metoprolol, sold as low pressor and Toprol XL, and ACE inhibitors like lisinopril, are significantly less effective when taken alongside ibuprofen. You may be managing your blood pressure carefully. You may be taking your prescribed medication every day, and ibuprofen may be quietly working against every effort you are making. The gastrointestinal protective lining is maintained in part by prostaglandins, the same compounds that ibuprofen blocks throughout the body. Prostaglandins stimulate the production of mucus in the stomach and small intestine, maintain the barrier between digestive acid and the tissue it would otherwise damage, and regulate blood flow to the gastrointestinal mucosa. When ibuprofen suppresses prostaglandin synthesis, all three of those protective mechanisms are weakened simultaneously. The mucus layer thins, the barrier becomes more permeable. Blood flow to the mucosal tissue decreases. The result is a stomach and intestinal lining that is significantly more vulnerable to the acid that is always present in the digestive system. In adults under 50, this vulnerability typically produces discomfort, the familiar stomach upset that the Advil bottle already warns you about. Take it with food, the label says, to reduce stomach upset. In adults over 60, the equation is different in two critical ways. First, the gastrointestinal lining itself has aged. The mucosal tissue is thinner. The regenerative capacity of gastrointestinal cells is slower. The baseline blood supply to the stomach wall is already reduced compared to younger adults. So the same prostaglandin suppression that causes mild discomfort at 40 causes genuine erosion and ulceration at 68. Second, and this is the point that kills people, gastrointestinal bleeding caused by NSAIDs in older adults is frequently painless. You do not feel an ulcer forming. You do not feel the bleeding when it starts. The first symptoms many people notice are weakness, dizziness, lightheadedness, or black tarry stools, all of which indicate that the bleeding has already been occurring for some time and that blood loss is significant. A study published in the Annals of Internal Medicine found that serious gastrointestinal events, meaning perforation, obstruction, or significant bleeding, occurred in approximately 1.5% of patients taking NSAIDs for 3 months and in approximately 4% of patients taking NSAIDs for 12 months. In adults over 75, those rates nearly doubled. The risk is amplified dramatically when ibuprofen is combined with low-dose aspirin, which is something tens of millions of people over 60 do routinely, taking their daily baby aspirin for cardiovascular protection and their ibuprofen for pain, not realizing that together they strip the gastrointestinal lining with a force that neither drug achieves alone. It is amplified further by blood thinners. Warfarin, sold as Coumadin by Bristol-Myers Squibb. Apixaban, sold as Eliquis by Bristol-Myers Squibb and Pfizer. Rivaroxaban, sold as Xarelto by Janssen Pharmaceuticals. If you are taking any anticoagulant and you also take ibuprofen, you are combining a medication that prevents clotting with a medication that damages the gastrointestinal lining. The result, uncontrolled gastrointestinal hemorrhage, is a medical emergency that claims lives every year in people who did not know that combination was dangerous. This is the risk that is least well known, and in some ways, the most important for adults over 60 to understand because it unfolds slowly, it does not present dramatically, and by the time it is recognized, it has already been accumulating for a long time. The brain, like the kidney and the gastrointestinal tract, is profoundly dependent on stable, well-regulated blood flow. The blood-brain barrier, the specialized layer of cells that controls what can and cannot pass from the bloodstream into brain tissue, is maintained in part by prostaglandins and the vascular signaling pathways they regulate. When ibuprofen chronically suppresses those pathways, several things begin to happen in the aging brain that have been documented in emerging research over the last decade. The first is disruption to cerebral autoregulation, the brain's ability to maintain consistent blood flow regardless of systemic blood pressure fluctuations. In older adults, this autoregulatory capacity is already diminished. Ibuprofen's effect on renal blood pressure regulation and sodium retention creates blood pressure variability that the aging brain is less equipped to compensate for. The result is periods of both overperfusion and underperfusion, too much blood pressure followed by too little, which damages the small vessels of the brain over time and contributes to the white matter changes associated with vascular cognitive impairment. The second is direct interaction with the clearance of amyloid beta, the protein fragment that accumulates in the brains of individuals with Alzheimer's disease. Early research, including work from the Johns Hopkins Bloomberg School of Public Health, suggested that NSAID might reduce Alzheimer's risk, a hypothesis that generated enormous interest. Subsequent larger trials, including the ADAPT trial, Alzheimer's disease anti-inflammatory prevention trial, found not only that this protective effect did not materialize, but that naproxen use and ibuprofen use in older adults were associated with increased cognitive decline in some subgroups. The ADAPT trial was stopped early because of safety concerns, specifically cardiovascular events in the naproxen group. But the cognitive findings were sobering. The anti-inflammatory hypothesis did not hold, and the population most likely to be harmed. Older adults with early cognitive impairment was precisely the population most likely to be taking these medications. The third concern is drug interaction with cholinesterase inhibitors, the medications most commonly prescribed for early Alzheimer's disease, including donepezil sold as Aricept by Eisai, rivastigmine sold as Exelon by Novartis, and galantamine sold as Razidine by Janssen. Ibuprofen affects the metabolism of several of these medications in ways that alter their efficacy and side effect profiles, and this interaction is frequently not discussed in clinical settings where the prescribing physician and the person recommending over-the-counter pain relief may be entirely different individuals. If you or someone you love is managing early cognitive decline and is also taking ibuprofen for pain, that combination needs to be specifically reviewed by whoever is managing the dementia care. Everything I have told you so far is only half of what you need. Because if all I do is take away a pain management tool without giving you a safe and effective replacement, I have not helped you. I have just left you in pain with nowhere to turn. So let me be direct about what the evidence supports for pain management in adults over 60 and what the specific products and approaches are. For mild to moderate pain, the kind that ibuprofen is most commonly taken for MIG-G, acetaminophen remains the safest first-line option for most adults over 60. You know it as Tylenol, manufactured by Johnson & Johnson and available at every pharmacy and grocery store in the country. The critical condition is dose. The maximum safe dose for adults over 65 with normal liver function is 3,000 milligrams per day, not the 4,000 milligrams listed on the standard adult label, because aging livers process acetaminophen more slowly. This means no more than 2 regular-strength 500 milligram tablets at any one time, taken no more than 6 times in a 24-hour period. Tylenol regular strength 325 milligram tablets allow slightly more flexibility. Tylenol extra strength is 500 milligrams per tablet. Do not take acetaminophen if you drink alcohol regularly, have liver disease, or are taking any other medication that contains acetaminophen, which includes many combination cold and flu products like Dayquil and NyQuil. For joint and muscle pain specifically, topical diclofenac is one of the most important and underutilized options in senior pain management. Voltaren Arthritis Pain Gel, now available over-the-counter at Walmart, CVS, Walgreens, and Target, is a 1% diclofenac sodium gel that you apply directly to the skin over the painful joint. Clinical trials have shown it to be as effective as oral NSAIDs for knee and hand osteoarthritis, or the most common pain conditions in adults over $60, with a fraction of the systemic absorption. Because the medication is absorbed locally into the joint tissue rather than circulating through the bloodstream, the kidney, cardiovascular, and gastrointestinal risks that make oral ibuprofen dangerous are dramatically reduced. The only common side effect is skin irritation at the application site. For inflammatory pain that is not adequately controlled by acetaminophen or topical diclofenac, for flares of arthritis, for post-procedure inflammation, for pain that genuinely requires an anti-inflammatory mechanism. The conversation to have with your physician is about short-course, low-dose NSAID therapy with gastroprotection. This means the shortest possible duration, the lowest effective dose, and simultaneous use of a proton pump inhibitor like omeprazole, sold as Prilosec OTC at every major pharmacy to protect the gastrointestinal lining during NSAID use. This is not a long-term solution. It is a supervised short-term approach for specific situations. For chronic pain management in adults over 60 DAs, meaning pain that has been present for months or years and is likely to remain, the evidence increasingly supports non-pharmacological approaches as the primary framework, with medication used adjunctively rather than as the main tool. Aquatic physical therapy has some of the strongest evidence for chronic musculoskeletal pain in older adults, specifically water-based exercise in heated pools, which is offered at many YMCAs and physical therapy centers. TENS units, transcutaneous electrical nerve stimulation devices, are available over the counter from brands like iRelieve and TechCare, sold on Amazon for between $30 and $60, and have solid evidence for knee, lower back, and shoulder pain management without any systemic drug effects. Capsaicin cream, specifically the 0.025% concentration found in Zostrix arthritis cream, available at CVS and Walgreens, works by depleting substance P in peripheral nerve fibers, reducing the intensity of pain signals in the treated area. It requires consistent daily application for 2 to 4 weeks before the full benefit is felt, but it carries no systemic risk whatsoever for adults over 60. Magnesium glycinate supplementation, the form found in products like Doctor's Best High Absorption Magnesium, available on Amazon and at Whole Foods, has meaningful evidence for reducing muscle cramp frequency and severity, which is a significant driver of nighttime ibuprofen use in older adults. The therapeutic dose is 200 to 400 milligrams taken in the evening. Discuss with your physician before starting, particularly if you have kidney disease. Here is the reality of modern primary care that makes this conversation so important. The average primary care appointment in the United States runs 18 minutes. In that 18 minutes, your physician is managing your blood pressure, reviewing your lab work, renewing your prescriptions, addressing your chief complaint, and documenting everything for regulatory purposes. The question of what over-the-counter pain medications you are taking and whether those medications are safe, given your specific medication list, your kidney function, your cardiovascular history, and your age, almost never makes it onto the agenda. Not because your doctor does not care, because there is not time, and because over-the-counter medications are so normalized in our culture that asking about them feels redundant. The result is that millions of people over 60 are managing their pain with a medication that is actively working against their kidneys, their heart, their gastrointestinal tract, and their prescribed medication regimen, yes. And nobody in their medical team has ever put all of that information together in one room. You can change that. At your next appointment, before you discuss anything else, say this: I want to review every over-the-counter medication I take, including pain relievers, because I want to make sure nothing I am buying at the pharmacy is interacting with my prescriptions or putting me at risk given my age and my kidney function. That question will get a substantive answer. It will take time. It may require a separate appointment, but it will get answered. And what you learn from that answer may be one of the most important pieces of information you receive this year. Because ibuprofen is not the only over-the-counter medication that carries elevated risk after 60. It is the most commonly used one. It is the most commonly misused one. And it is the one with the clearest, most documented, most preventable harm profile in the elderly population. You have spent decades building a body that has carried you through everything. It deserves the same care and attention in how you manage its pain as in how you manage everything else. Drop a comment below and tell me, how often do you take ibuprofen? And did your doctor ever tell you about these risks? I read every single comment, and your experience matters to this community.